Well, good morning, and thank you for joining us for this morning's PGY2 Pain and Palliative Care webinar series. I'm pleased to welcome this morning Dr. Moya Romero, who is a PGY2 Pain Management and Palliative Care resident at the West Palm Beach VA. She's going to be speaking to us this morning about migraine prevention and some of the more novel agents that have recently come out that we can utilize. If you would, please make sure to mute yourself until such time as there are questions to be asked. And with that, I will turn it over to Dr. Moya Romero. Thank you.
Hello, can you hear me?
Sound good.
Hopefully you guys can hear me. Okay, perfect. So thank you for the introduction. Like Chris said, I'm Dr. Moya Romero, and I'm the second year pain management and palliative care resident at the West Palm Beach VA Medical Center. And today we're going to be talking about novel agents for migraine prophylaxis. The slides. So I have nothing to disclose today. And by the end of the presentation, you will be able to identify and compare or contrast the clinical features of cluster, tension, and migraine headaches, differentiate between abortive and prophylactic migraine treatments, review available novel migraine prophylaxis medication, and if given a patient case, select an appropriate candidate for migraine prophylaxis with the novel agents. I wanted to start off by giving a little bit of background on headaches in general. Headaches are among the most common central nervous system disorders, with about 50% of the adult population reporting at least one headache in any given year, and about 30% of those 50 is reported as migraine headaches. Headaches are also associated with personal and societal burden for pain, disability, damaged quality of life, and financial costs, which they are the third highest cause of worldwide disability, and migraines being the sixth worldwide disability cause. Headaches are in general underestimated, underrecognized, and undertreated worldwide, and it's estimated that about 60% of migraines go undiagnosed. How do we classify headaches? Headaches are basically classified into primary headaches and secondary headaches. Primary headaches are those that have no identified underlying cause, and some examples of primary headaches include migraine headaches, tension type headaches, and cluster headaches. And then secondary headaches are those that are caused by another condition or treatment, and one example is medication overuse headache. In terms of classification or pain description and diagnosis for the three primary headaches, which would be more of like the focus of the presentation since we're going into migraine a little later. For tension type headaches, these are characterized by a mild to moderate pain that is bilateral and pressing or tightening in quality. It can last anywhere from 30 minutes to 7 days, and it could happen with or without photophobia or phonophobia. You have to have at least 10 or more attacks that are consistent with the description above. When we go into migraine classification, migraines are characterized by unilateral, pulsating, moderate to severe pain that is aggravated by routine physical activity. It also can have additional manifestation, which can include nausea, vomiting, photo or phonophobia, and it can also present with or without aura, which is basically a fully reversible manifestation that can be visual, sensory, motor, or speech disturbances that usually progresses or develop gradually. It can last about an hour. Migraine headaches normally can last anywhere between 4 and 72 hours. For them to be diagnosed, you have to have at least 5 headaches plus 2 features from number 1 above and at least 1 feature from number 2. So either photo or phonophobia, additional nausea, vomiting, things like that. And then in order to be classified as a chronic migraine, you have to have at least 15 days of migraine per month for over 3 months. And this really only happens in about 2% of migraine cases. And patients have to take so much medication for these type headaches that it can turn into a medication overuse headache problem as well. And last but not least, we have cluster headaches, which are characterized by severe to very severe pain that is sudden, excruciating, and penetrating in nature. It definitely includes other symptoms such as rhinorrhea, lacrimation, nasal stuffiness, eyelid edema, or restlessness. The unilateral pain presents in clusters that last weeks to months, and then patients have a attack-free interval that can last up to 2 years as well. For diagnosis of cluster headaches, you have to have at least 5 severe unilateral headaches, between 1 headache every other day to 8 headaches per day, plus another symptoms, the ones that I mentioned before, such as nasal stuffiness, facial sweating, etc. For those of you who are a little more visual learners, I know the previous slide probably gave you tachycardia, but you have a more picture here that you can see the different types of headaches and where they affect the patients in general. So for tension type, you can see is a bilateral type of pain, which is like a vein-like kind of pressure. For migraine is a throbbing type of headache that happens only unilateral. And then for cluster headaches, we have purebell, sharp type of pain that is accompanied by lacrimation and the other symptoms that I previously mentioned. Now, when we're talking about headaches and the patient population that we would have in front of us, it is very important to set up treatment goals that are realistic for those patients. And some of the attainable treatment goals for this patient population is definitely restoration of function, reduction in headache frequency, reduction in stability and severity or duration of the headache, prevention of escalation to chronic status, and then improvement in quality of life. So one thing that is very important to talk to our patients about is the fact that remission or cure may not always be possible. So patients need to set realistic goals for themselves, and that's important to set up ahead of time. They need to be aware that it's not necessarily cure what we're looking for with the treatment of headache or migraines. So in addition to setting up goals and realistic expectations, we also should encourage our patients to be actively involved in their headache management in order to achieve better outcomes. And how can they do that? There's a few lifestyle management actions that they can take, including keeping a migraine or a headache diary. What this does is that it allows them to identify different triggers that lead to those headaches or migraines in general. Now, once they identify those triggers, they can minimize exposure to them, as well as any modifiable risk factor. And definitely adherence to pharmacologic and non-pharmacologic recommendations is very important. It is estimated that about 70% of patients avoid or delay taking abortive headache medication because they're waiting to see if they're really having a migraine or a headache. They're concerned about the side effects of the medication they're taking. They fear the addiction to the medication, or they worry about the different insurance limits put on the abortive medication. There's also an unspecified percentage of patients that delay taking prophylactic or preventative medication because they don't feel either that the therapy is effective, they have anxiety about different side effects with the medication, or they prefer not to take a daily medication, even if it will be to prevent their migraines. I just mentioned different triggers that patients can avoid, but it is very important to recognize that there are medications or substances, as well as environmental factors or even food factors that are known to be triggers for headaches. And these are information that we can give the patients ahead of time. So some medications or substances that can cause or lead to headaches upon initiation include phosphodiesterase inhibitors, alcohol, and oral contraceptives. We have on withdrawal substances that can cause headaches or lead to headaches are caffeine, opioids, and serotonergic antidepressants. Then with occasional use, nicotine, nifedipine, and atropine can cause or lead to headaches. And then with long-term use of amiodarone, lithium, and thyroid hormone replacement products, they are another trigger for headaches with long-term use. And then known environmental triggers, definitely stress or release of stress, loud noises, disturbed sleep patterns. So for our patients that work either 7 on, 7 off, or work 1 week during the day, 1 week at nighttime. So all these disturbed sleep patterns can definitely lead to headaches and migraines. Motion sickness is another one, menstrual events, and strenuous exercise. And known food triggers include chocolate, processed or fermented or pickled, marinated foods, baked goods, dairy products, or tyramine-containing foods. So basically anything that tastes good can lead to a headache. Now, I just wanted to, for kind of like completeness for the presentation, I wanted to present to you some of the abortive or acute migraine treatments that are currently being used. Basically, we have the triptans, which are serotonin receptor agonists, and they're the mainstay in therapy for abortive treatment. So they're like the first line treatment recommendation for this patient population and this indication. They should be used as early as possible. So from the previous statistic that I mentioned, avoiding to take those abortive medication is an issue, and a lot of patients do that. So it's important to counsel the patients on this fact. You will definitely want to look for drug-to-drug interactions with these agents and any other serotonergic agents. They are used to treat moderate to severe migraine headaches. And there are several formulations available, which is a plus when we're talking about this medication class. Then second line treatment, we have the ergot alkaloids and derivatives. We have ergotamine, dihydroergotamine. These are similar in mechanism of action, but they're less specific, so they have more side effects. They're used to treat moderate to severe migraine headaches. They have injectable and nasal spray formulations, which is also favorable for them. You're going to probably see dihydroergotamine used more often because it has less emetic potential as well. So that's another difference in there. Then we go to the non-opioid analgesics. So we have aspirin, non-steroidal anti-inflammatory agents, or Tylenol or acetaminophen. We use those for mild to moderate migraine headache. Tylenol or acetaminophen is preferred in pregnancy, and ketorolac intramuscular can be considered in the emergency department if a patient comes with a very severe migraine. We definitely want to monitor for different comorbidities and drug-to-drug interactions. There's patients that are not able to take any or some of those medications that we just mentioned. Barbiturates, they're also used for occasional moderate to severe, or occasionally used for moderate to severe migraine headache. They have a very high risk for overuse. So it's important to look for that. And then lastly, opiate analgesics, which are used to treat moderate to severe migraine headaches. They're basically used as a rescue therapy. It will be like a last line therapy for abortive migraine treatment. You definitely want to limit its use, especially the parenteral formulations. We have to worry about sedation, respiratory depression, any other potential side effects. It's one of the medications that leads to medication overuse headaches. And like I mentioned before, it definitely should be used as a last line therapy. Now we're moving into prophylactic medication. When we talk about this, first we want to mention the non-pharmacologic recommendations that we can have for our patients. And we can start with cognitive behavioral therapy. We also have acupuncture. We have exercise, which basically includes like stretching exercises most likely, and then relaxation. And all of these have evidence to support their use as a treatment, non-pharmacologic treatment for migraine. Then I wanted to briefly touch on the pharmacologic treatments that have been traditionally used before these other agents actually became available. And no matter what, when we go through that, we'll know that we're still going to have to try some of these before we can go to one of the novel agents anyways. But traditionally, we've used medications that I'm really going to cover more the ones that have quality of evidence level A. These have like long standing evidence to support their use as a prophylactic agent for migraine. And we'll start with the beta blockers. We have propranolol, which is actually a drug of choice in pregnancy for migraine prophylaxis. We can dose it 80 milligrams by mouth daily. We do the immediate release in divided doses, and it can go up to 240 milligrams daily. Metoprolol tartrate, 50 to 200 milligrams PO daily, and this is an off-label use. And timolol, 10 milligrams PO twice a day. It could be up to 30 milligrams daily, and this is also an off-label use. Things to take into consideration, some relative contraindications. We have asthma, heart block, hypotension, bradycardia. They're all relatively safe in pregnancy, but as I mentioned before, propranolol is really the drug of choice in that patient population. Then we go into antidepressants. We have amitriptyline, which could be dosed anywhere from 10 to 150 milligrams PO daily, is also an off-label use. Relative contraindications for this one include heart block, bipolar mania, urinary retention, any prostate disease, and is definitely contraindicated within 14 days of an MAOI. Anti-epileptic medication, we have divalproex, 250 milligrams twice a day with a max of 1,000 milligrams PO daily for the delayed release. 500 milligrams PO daily for 1 week, then 1,000 milligrams PO daily for the extended release. Sodium valproate, 800 milligrams PO daily, or 1,000 to 1,500 milligrams PO daily, and this is an off-label use. And we definitely need to be careful with this one because it needs a slow taper due to a high risk of seizures. We need to taper the patients off this medication. And then topiramate, that was for topiramate. We definitely need, for sodium valproate, we need to maintain plasma concentrations about 50 milligrams per deciliter, and then topiramate is the one that we do need to do a slow taper due to high risk of seizures. And it can be dosed 100 milligrams PO daily in 2 divided doses and titrated by 25 milligrams per week IR formulation, and then 100 milligrams PO at bedtime, titrated by 25 milligrams per week for the ER formulation. Relative contraindications, we have liver disease, renal impairment, obesity, underweight, bleeding disorders, and you want to avoid all of these agents in the pregnancy population. This other slide really basically only gives you names of other medication or other prophylactic agents that have some level of evidence to support their use for this indication, either category B or C. Some are FDA approved and some are off-label use for migraine prophylaxis. But then I didn't want to go into a lot of detail on those because we have a lot more to cover. Another prophylactic agent that has gained popularity in the last years is onabotulinum toxin A, or Botox. Botox is a acetylcholinesterase inhibitor and neuromuscular blocking agent. FDA approved in 2010 for prophylaxis of headaches in adults with chronic migraine headaches. A single-use dry powder for reconstitution and normal saline is how it is provided. The dose is up to a total of 155 units. And the way they do it is they inject about 5 units per site and is divided across 7 head and neck muscles. They have 31 different sites that are evenly distributed bilaterally, and you can only dose it every 12 weeks. And you don't want to exceed 400 units total administered in an interval of 3 months. And the reason why I say that, even though it's up to 155 unit total dose for migraines, we do use Botox or this product for other indications. So in total, you don't want to use more than 400 units in a 3-month interval. Placing therapy, really we use it for migraine prophylaxis or chronic migraine prophylaxis. It can take up to 6 months for maximum benefit. So basically you would have to probably dose it twice or administer it twice before the patient start having the desired effect. It has a black box warning for distant spread of toxin effects, which can happen hours to weeks after the injection. It can lead to swallowing, breathing difficulties. It can be actually life-threatening. Adverse effects with this medication or this product are injection site pain, headache, cardiac dysrhythmias, and anaphylaxis reaction. So I just had a little quick assessment question. My slideshow screen is not working, so we're gonna have to bear with me for a minute there. But which of the following agents is FDA approved for migraine prophylaxis? And I'll just give you a couple seconds so that you can think about it, and then I'll give you the answer. So we have metoprolol tartrate, amitriptyline, sodium valproate, all of the above, or none of the above. So basically, none of the above is the correct answer. None of those agents are FDA approved for this indication. The agents that we covered in the slides that are FDA approved for this indication are propranolol, valproic sodium, topiramate, and Botox, basically. So now we're going into the novel prophylactic agents for migraine. So these are definitely 3 monoclonal antibody agents, and the names are arenumab AOOE, which was FDA approved for migraine prophylaxis in May 17, 2018, so last year. Fremonizumab VFRM, FDA approved in September 14th of last year, 2018. And then we have galcanezumab GNLM, which was FDA approved September 27th of 2018. So these are very, very novel agents that have been approved within the next year, the past few months, I'm sorry. So if you're curious, just like I was, you may be wondering where the 4-letter suffix is coming from behind each of the generic names. So what I was able to find on this subject is basically that in 2017, the FDA released the non-proprietary naming of biological product guidance, where they recommend a unique, devoid of meaning, 4 lowercase letters attached to the name of the drug in an effort to prevent confusion and avoid substitution of biological products that have not been deemed interchangeable. So this is actually to help us have any confusion with the naming or the utilization of these products. And if you're wondering about the naming of the monoclonal antibodies, I also did a little bit of research on that. And for those that end in Zumab, these are humanized monoclonal antibodies, which means that they're closer to human antibodies than to other species. And then the ones that end in Umab are fully human monoclonal antibodies that were developed through various technologies or technological advances that end up being very, very costly. So going in more detail into the 3 different agents. These are calcitonin gene-related peptide, or CGRP receptor antagonists. And they act at very different levels. So when they bind to the receptors located on the mast cells, these agents inhibit inflammation. When they bind to the receptors located on the smooth muscle cells, then within the vessel walls, they inhibit dilation of the arteries. And when binding to receptors located on the postjunctional cell, they suppress enhancement of trigeminal nerve pain and inhibit pain transmission. So that's basically the mechanism of action for all 3 of these agents were classified under the same class of medication. So now we'll discuss a little bit of the clinical trials that led to the approval of these agents for migraine prophylaxis. The first one will be arenumab, and this trial was actually titled Safety and Efficacy of Arenumab for Preventative Treatment of Chronic Migraine. This was a randomized, double-blind, placebo-controlled, multi-center phase 2 trial. It included 667 patients. The study actually took place in 69 headache and clinical research centers in Canada, US, and 8 European countries, including the United Kingdom and Germany, and lasted a total of 31 weeks that was divided into the initial screening time, the baseline phase, the treatment phase, and the safety follow-up phase, which was the last 2 lasting about 12 weeks each. They included patients that were adult patients between 18 and 65 years of age with history of chronic migraine. And they excluded those that had Botox injections in the past 4 months, any history of cluster or migraine headache with continuous pain, and no response to prior prophylactic agent after an adequate trial. Endpoints, they were looking primarily at a mean change in monthly migraine days from baseline, the baseline phase to the last 4 weeks of the treatment phase. And the secondary endpoints were at least 50% reduction from baseline in monthly migraine days and a change from baseline in cumulative headache hours of any severity. What was the treatment, or how what was the intervention for these patients? They did a 3:2:2 randomization to placebo with erenumab 70 milligrams, erenumab 140 milligrams for 12 weeks. And what they did is for the 140 milligrams, they needed 2 subcutaneous infusions. And what they did is they brought the patients in at the study centers on day 1, week 4, and week 8. And these patients were keeping an electronic diary. When we look at the results and the way they posted the results, we can see that everything that they tested for, everything that they were looking for, was really statistically significant, except for the cumulative monthly headache hours, which was a non-statistically significant result. And when we look at the plot, we can see how both the 70 milligram and the 140 milligram doses proved to be actually superior to placebo, with also a significant p-value of less than 0.0001. I just wanted to also show you what they found in terms of adverse events. And as you can see, it's really the safety profile was pretty benign. They did have some patients with upper respiratory tract infection, some nausea, constipation, muscle spasms, and of course migraines as well. Then we go into fremanezumab. Fremanezumab, the trial that we looked at was a fremanezumab for the preventative treatment of chronic migraines. Inclusion criteria, they had adult patients in between 18 and 70 years of age with a migraine history of at least 12 months, and it had to be a chronic migraine. Exclusion criteria included patients that had Botox injections in the past 4 months, any nerve block or magnetic stimulation in the past 2 months, and lack of efficacy of at least 2 prophylactic treatments at an adequate trial. The primary endpoint that they were looking at was a mean change in monthly migraine days from baseline to the 12-week period after the first dose. And secondary endpoints were mean change in average number of migraine days per month, percent of patients who achieved at least 50% reduction from baseline in monthly migraine days, and a mean change in average number of days of abortive medication used from baseline as well. This actually, patients were recruited for at least 132 sites in 9 different countries, by the way. And it included a total of 1,130 patients in the trial. Intervention was a 1:1:1 randomization of fremanezumab quarterly and fremanezumab monthly and placebo. All patients received 3 abdominal sub-Q injections at baseline and 1 injection at weeks 4 and 8, and all patients actually also kept an electronic diary. Then you have the differences for the 2 different doses. When we're looking at the plot, we can see that there was a p-value that was statistically significant for all differences versus placebo, and for the comparison with placebo with respect to the percentage of patients with a reduction of at least 50% in the average number of headache days per month. And we're looking at both the monthly and the quarterly injections actually were proved to be have a very benign also safety profile, and proved to be effective for migraine prophylaxis. But always, one thing they mentioned in their trial too is always keeping in mind that the long term effect of this medication is obviously unknown at this time. And last but not least, we have galcanezumab, which the trial that we looked at was effect of different doses of galcanezumab versus placebo for episodic migraine prevention. This was a phase 2b study comprised of 4 study periods for a total of 3 months. They had a screening and washout period, they had a prospective baseline period, and they had a double-blind treatment period followed by a post-treatment period. It also included 1,130 patients. And they actually were able to achieve 90% power in the study based on the intention to treat population. And the baseline characteristics for all the patients were the groups were very similar, with the main difference being the percent of female versus male in the different trials. In different groups. Inclusion criteria, we have adult patients 18 to 65 years of age with a migraine history, and at least 2 migraine attacks in the last 28 days prior to the study. They excluded, again, patients with any Botox injections 4 months prior to the study, or lack of efficacy of 2 or more prophylactic agents with level of evidence A or B. And as you can see, this is a common theme between the 3 different trials that we just talked about. And that's why when I went over the traditional prophylactic agents, I said that those are still going to be utilized even with the approval of these novel agents, because the way that they are studied, actually the patients had to fail at least 2 of those agents before they're considered an adequate candidate for one of these novel agents. In terms of endpoints, they're looking at primary endpoint of 1 or more dose being superior to placebo in the prevention of migraine, and achieving 50 or 100% reduction in number of migraine headaches per day during the treatment period. They did a 2 to 1 to 1 to 1 randomization to receive 1 dose of placebo versus a dose of galcanezumab at a 5 milligram dose, 50 milligram dose, 120, and a 300 milligram dose. And this is also administered in a sub-Q route. When we look at the plot, we can see how the change in the number of migraine headache days was significant for all the different doses, being superior to placebo. And when we look at the change from baseline and the level of functional impact at the endpoint, we see that the 5 milligram, 120, and the 300 milligram doses were really the more successful ones when comparing to placebo. Once again, we see a very benign side effect profile, and the authors really of this study concluded that more trials needed to be done for more information to be obtained and to actually specify which dose was going to be the more effective one for the specific patient population. So that was a little overwhelming going through all the studies, but what I did was I put together a comparison chart for you for your future reference that includes the 3 different agents, and we covered the dosage, administration, the available products, what to do when you miss a dose, any black box warning or contraindication, most common side effects, and the average wholesale price. So just briefly going through the 3 different agents, we have the erenumab can be dosed 70 or 140 milligrams sub-Q once monthly. It's administered or is injected to the abdomen, thigh, or upper arm. The product is available as a 70 milligram pre-filled auto-injector. So when the patients need to get the 140 milligram dose, they're actually going to receive 2 injections at that point. If you miss a dose of this medication, you want to administer as soon as possible, and you want to dose or take the next dose exactly 1 month after the dose that you just took. So if you missed it by a week, then you don't go by that old date, you go by the date that you actually received the injection. There is no black box warning or contraindication listed for erenumab. Most common side effects were injection site reactions and constipation. And it can cost up to $345 per dose. And I'm not sure that since this is such a novel agent, insurance companies would need a prior authorization in order to cover this treatment regimen, and it would have to have a lot of patients would have to try a lot of other medications before they actually get approved for this one. Then we have fremonezumab, which is actually dosed at 225 milligrams sub-Q monthly or 675 milligrams sub-Q quarterly. It can be injected to the abdomen, thigh, or upper arm, just as erenumab. It comes as a 225 milligram pre-filled syringe. So the patients, again, for the higher dose is going to have to receive 2 or more injections. If you miss a dose, you want to administer as soon as possible, and the next dose should be scheduled 1 month or 1 quarter after the last injection. Warning or contraindication is included as a serious hypersensitivity reaction to the medication active ingredients or the inactive ingredients in the formulation. Most common side effects, really injection site reactions, is what they mentioned, and it can cost $460 per dose. And last but not least, we have galcanezumab, 240 milligrams loading dose, followed by monthly 120 milligram doses. You want to inject it to the abdomen, the thigh, the back of the upper arm, or the buttocks, and that's a little different from the other two. It's available as a 120 milligram pre-filled pen or syringe. So once again, a couple injections for the loading dose is needed or are needed. You want to administer as soon as possible if you miss a dose, and the next dose you want to schedule it 1 month after that missed dose. It can cause serious hypersensitivity reactions, and that would be a black box warning or contraindication for continuing with treatment. Most common side effects, injection site reactions again, and then it costs $690 per dose. Now we have a assessment question for you, followed by the patient case. So choose the answer that applies to fremonizumab. Is FDA approved or Food and Drug Administration approved for migraine prophylaxis? It is administered as a monthly intramuscular injection. It is administered to the abdomen, thigh, or upper arm. And most common side effects are gastrointestinal side effects. Is it A, B, and C, or A and C? So the answer will be F, which is A and C. Now we're going to go into the patient case, which will be the last portion of the presentation. We have a couple minutes for questions if you have any. We have EBR, who is a 27-year-old female school teacher with a past medical history of migraine headaches without aura. She was diagnosed at age 14. She has also allergic rhinitis and anxiety. She's a mother of 3. She has a toddler twin boys and a 5-year-old girl. She's not breastfeeding anymore. EBR's migraines have become more severe and frequent, going from 8 to 18 migraine days per month within the past 2 years, which is affecting her work and social life. She has no known drug interactions or drug allergies, sorry. Current medications used, she uses acetaminophen as needed for pain. She has sumatriptan, PRN at onset of migraine, cetirizine for allergies as needed, and she also takes a 1-a-day women's multivitamin. Non-pharmacologic interventions that she has trialed in the past include acupuncture, yoga, and relaxation techniques. And medications trialed in the past are propranolol, which was effective, but it was discontinued due to side effects, and triptyline, which was effective after a trial of 2 weeks. So the first question is, what other non-pharmacologic recommendations can EBR try at this point? Keeping a migraine diary, avoiding migraine triggers, going into CBT, all of the above, or none of the above? So if you think about it, she has already tried some of the recommended pharmacologic or non-pharmacologic recommendations, so acupuncture, exercise, or relaxation, yoga. So in this case, the answer will be all of the above. It's definitely important that for her to keep a migraine diary and avoid the triggers, and CBT will be another non-pharmacologic recommendation that we can have for our patients. So what pharmacologic recommendations can you make for EBR in terms of migraine prophylaxis at this time? We can recommend a propranolol retrial, amitriptyline retrial, or we can consider erenumab trial, or going to an opioid with oxycodone acetaminophen trial. I'll let you think about it for a minute or a few seconds. At this point, and for the pharmacologic recommendation for our patient would be to retrial amitriptyline, which will be B. And the reason for that is because she really only tried the amitriptyline for about 3 weeks, and you need a 2 to 3 month trial to assess the efficacy of the treatment. So it's important for her to have an adequate trial of this more traditional prophylactic agent prior to us recommending something else for her. So after 4 months, so she has tried that for 4 months, EBR returns to your clinic stating that she has not seen any reduction in the migraine days per month and is about to get fired from her job because she keeps calling out sick. She states she does not have time to take her daily medication with the chaos in her house. At this time, what would be your recommendation for migraine prophylaxis for EBR? Would you want her to continue amitriptyline because you're unable to assess the effectiveness or efficacy at this time? You want her to register for more yoga classes at the community gym? You want to initiate a trial with the Renumab 70 milligram sub-Q once monthly? Or you want to increase her dose of sumatriptan? So after 4 months and her actually not being able to take her prophylactic medication daily because of everything that goes on in her house and her normal routine, it will be an adequate choice to initiate one of the new or novel agents because this will definitely increase the compliance with the medication. And this will be something that she won't have to do more than once a month. And it could definitely help her in terms of migraine prophylaxis, in terms of like keeping her job, in terms of improving or having actually being able to have a social life and perform at home the normal basic routine without those migraines that are occurring so frequently nowadays for her. So some of you may be asking, what about Botox? Because she didn't really try that yet. It's definitely a valid option to consider. She does have chronic headache or migraine, and you can do every 3 months, which would increase adherence or compliance to the treatment. So that could definitely be a perfect good option for her too. Now, a caveat is if you were to consider any of the novel agents, you have to remember that you would not be able to use the agents within 4 months of the last Botox injections if you were to trial that first, because that is really how they were studied in all of the different trials for the 3 different agents that we covered during the presentation. So EBR has seen tremendous improvement in migraine headaches with a reduction from 18 to 7 migraine days per month after 3 Renumab injections. Today, she calls the clinic asking when her next injection is due since she forgot to enter this month's appointment in her calendar. You notice this month's dose should have been given at the previous week, and she's now 5 days late past her dose date. What is your recommendation for EBR? You want her to come to the clinic today if possible to receive the missed dose. Come to the clinic Friday, which would be 9 days post the missed dose, to receive the missed dose. Make an appointment for exactly 1 month after the dose that she already missed, and or switch to another CGRP agent since this one or this dose does not seem to be effective for her. So at this point, based on the recommendations from the trials and the package insert and the FDA approval, you definitely want her to come to the clinic today or as soon as possible. If it's not today, it could be tomorrow, the day after, to receive the missed dose. You don't want to delay that injection. You want to try to give it as soon as possible after the missed dose. And what you do is after you give this dose, you want to schedule the next one for a month after the day that she actually received the injection. So that's important to know too. So that's it for our patient case. I hope you enjoyed it and you learned a little bit during the presentation, but what is now on the pipeline? So now that we have those 3 agents available and approved for migraine prophylaxis, what is next? So we have another agent that is actually being studied at the time. It's called eptinezumab. It's another CGRP receptor antagonist. The ongoing trial is actually called the PROMISE-2 trial for chronic migraine prophylaxis. They're looking for efficacy and safety of this agent. It has promising results with further migraine reduction after 3 to 4 infusions. So this one is going to be administered quarterly. So that's another important fact, and that's why I wanted to include in the patient case that the patient, after 3 injections, she saw a great improvement in her in terms of migraine prophylaxis. So it might not be the first injection that do the trick. It may need to be more than 1 injection for our patients to see the actual effect of these monoclonal antibody agents. So the clinical pearls to finish the presentation, we have migraines are unilateral, pulsating, moderate to severe pain with or without aura that is aggravated by routine physical activity. Abortive treatment should be used at the first sign of migraine, which is a very important counseling point for our patient population, for this patient population. Prophylactic agents to be chosen based on patient characteristics. As we saw, even though we tried to retrial the more traditional agents, the patient was not being adherent to the treatment because she couldn't do it because of their daily routine. So you actually have to choose the agents that the patients are going to be more successful with. Non-adherence to daily prophylactic regimen is a key factor to initiate novel CGRP injectable regimen, as I just mentioned. And it's important to let our patients know, and for us to know as clinicians too, 50% reduction in headache frequency is actually considered a successful treatment. As I mentioned at the beginning of the presentation, it's important to set realistic goals and expectations for these type of treatments. And actually a 50% reduction is considered a very successful treatment at this point. Thank you all for your attention. And now I'm open for questions if you have any. I don't know if anybody can hear me.
Please feel free to use the chat box as well if you have any questions.
Yes, please. I'm going to try to check that too. Oh. Here. There we go. Found it.
Hi, I have a question. Can you hear me?
I hear you, yes.
So I was just wondering, when would you start a prophylactic medication? Like is there like a cutoff with how many headaches a person would have per month that you would decide, okay, maybe we need to start prophylaxis?
That's actually a decision between the patient, the specific patient, and the provider. I know because I have a few friends that actually suffer from migraine treatments. I actually haven't done a rotation in that area yet, but I do know from my reading as well, it's not necessarily like a cutoff, like a specific cutoff. When you see that the migraine is actually affecting the patient's daily living and their work and their study, if they go to school, things like that, that's definitely a point where you would consider a prophylactic agent. I don't think that there's necessarily a cutoff as to how long they have to have a migraine for or anything like that, but they, as soon as something is so severe that it affects their own life, you know, if they get 1 migraine a month, they might be like, okay, that's fine, I can deal with that. But if they continue to get migraines and they get like 5, 6, 7 days of migraine a month, that might be significantly affecting their activities or what they do in their life. So that might be a good point to which you would initiate prophylactic agents.
Okay, thank you.
You're welcome. See if I think I saw something in the chat. Sure, I can send the slides if you guys want to share it for sure. Any other questions? If not, I appreciate you guys' attention. Thank you so much for joining today. You can actually email me. I'm actually going to put my email in the chat as well. I'm going to put my email in the chat as well so that you can email me if you have any other questions or if you want me to forward you the presentation.
Well, thank you very much. That was a wonderful overview and presentation of migraine. Thanks to all of you for signing on this morning. The presentation was recorded and will be available on the Society of Pain and Palliative Care Pharmacists website after we conclude. So thanks again, and thank you for such a wonderful presentation.
Thank you for having me.